It starts.
Okay. Right. Okay. We have the first two cases, I think, one by Dr. Otri and one by Dr. Anugupta. Otri, you're starting first, I can see. So who's your senior resident?
My resident, unfortunately, will not be able to join.
Okay.
She has an emergency, so I'll be
Okay.
presenting.
You'll be presenting. Okay. Great. Okay. So I think you can start. Welcome everybody and to the session. Two very interesting cases. Let's start. Otri.
Good morning, everyone. Start with my case and welcome everyone on this cloud-covered Sunday for being online on a Sunday morning and discussing Alzheimer's disease. What a great utilization. So my case is a
Atri,
kind of a
please do
long
Atri.
case.
Dr.
Yes.
Atri, do it on slideshow,
Yes.
please. Slideshow.
So this is the story of a 62-year-old lady who was right-handed, a homemaker, who came to the cognitive neurology with her family. The family was particularly concerned with memory symptoms that had started in the past 6 months. Soon after the wedding of her younger daughter, a few weeks later, she was unable to recall the details, and one occasion she was unable to remember that her daughter was married. So this particular incident was very alarming to them, and they came to me. On taking a history, there were other symptoms of recent memory impairment. For example, she was having difficulty in remembering her recipes and had to call her sister. But in other cognitive domains, such as managing her household affairs, using gadgets, traveling alone, she was able to do all these tasks independently. She denied a change in her mood, and there was no change in behavior that was observable to the family. Her past medical history was significant for hypertension and dyslipidemia. She was already on the beta blocker, statin, aspirin, and when she went to her family physician with the memory symptoms, she had already started her on donepezil and memantine. Social history: she was a postgraduate, but lived at home, lived with her husband, who was a retired government employee. They shared their household chores. One of their daughters lived close by and visited them almost every day. And her hobby was spending time preparing Ayurvedic remedies at home. Physical examination was normal. MMSE score was 28 out of 30. She lost 1 point in serial subtraction and 1 point in recall. And I'll just show the MOCA form. So she lost the point in trail B. She was doing it okay until the very end when she committed an error. The clock drawing was slightly unusual. She started and then she gave up suddenly. Lost a point in naming, although otherwise during the conversation she was very fluent. Attention appeared okay. Lost a point in the sentence repetition. Phonemic fluency on the lower side. Could not mention any of the similarities. And lost all 5 points on delayed recall, although was able to recall 4 out of 5 words on the queuing. The memory subscore was low. It was 5 out of 15. So at this point, I thought of an amnestic multi-domain mild cognitive impairment. The prominent amnesia appeared. At this point, we didn't have biomarkers, right? So I thought that this is possibly going to be underlying pathology. I discontinued the memory and kept donepezil on, although at that time, donepezil was not indicated for MCI. So after 3 months, The patient became more aware of memory symptoms. She was always anxious that she is forgetting and trying different supplements for her memory symptoms. On one occasion, when she attended a wedding with her family members, she suddenly felt very anxious, panicked, and had to leave because she was having severe palpitation. And on another occasion, a slightly unusual incident that after a nap in the afternoon, she woke up and thought it's 5 a.m. So she went out and to get milk, where usually she used to go out in the morning. But despite this incidents and her increasing complaints, family members didn't notice any significant functioning, any significant repetition of conversations or repetitive questioning. They did observe that the patient was sleeping poorly, only 3 to 4 hours at night. Again, the physical examination was normal. The MoCA score seems to have improved by 5 points in these 5 months. An MRI was done in the meantime, and which was normal. So I'll just show you the MoCA score. So again, the trail B point was lost, but the pattern, she starts well and then loses track. This time she was, hello?
No, please.
This time she complete the clock drawing, but the numbers became crowded towards the end, and there was a frontal pool, as you can see. The naming, now she was able to kind of recover that lost point. Phonemic fluency remains the same, lost 1 point in repetition. Memory delayed recall with the same word list seems to be fluctuating. Now she was able to recall 2 words, and the memory subscore was around 11. Orientation was fine. So because within 3 months the MoCA scores increased and the MRI brain was normal, so, and there were confounding factors including anxiety and poor sleep, so I started the patient on mirtazapine and gradually increased the mirtazapine. Now moving on, this is follow-up after 1 year. Now after 1 year, so this is approximately 1.5 years from symptom onset. Now the patient reported improvement in memory. The husband also felt that the memory of conversations and important dates, remembering birthdays, was much better than what it was during the last visit. The patient is also more interested, going out regularly alone, speaks fluently. There is no difficulty in remembering the TV soaps that she followed. Sleep is better, and the anxiety is also significantly better. The MoCA score and MMSE scores have remained almost stable. The MoCA scores have further improved. So from 17 to 22 to 27 now. CDR-SB is 0.5 due to mild memory problems. And at this point, I felt that this is unlikely to be a degenerative pathology. So I sought opinion from psychiatry. And the psychiatrist started her on sertraline. She kept the donepezil on. At this point, I like to kind of stop and ask my seniors about their opinion about what they feel is appropriate, or what we should have done. Sir or madam?
Atanu or Manjari, one of you please take it up.
Yes, very interesting observation did, and over the a period of more than 2 years almost. So I would say that patient consistently exhibited some memory problem, and that was documented also with both MoCA and MMSE. But what was more interesting was that the initial MoCA showed a very low score, which improved subsequently, and with some intervention, maybe by controlling her anxiety symptom, But this I personally feel that anxiety itself can result in reduced performance or impaired score in any of the neuropsychological test. Although the initial clock was showing a very abnormal, and that improved in the subsequent, studies. But it is a common observation that many of our Indian patients, they are not accustomed to this neuropsychological test, paper pencil test, and they often fail to perform and deliver the desired score. And maybe in the next time they perform well because of the circumstances and they become accustomed to. But I personally feel that this person is not having a secondary cognitive impairment secondary to anxiety. He is having some underlying pathology in the brain, degenerative, and having the memory problem consistently. She must be kept in radar under your radar, and in modern days we need to investigate her with the other sophisticated biomarkers. This is my opinion. Dr. Amitabh and Manjari and Suman.
I do agree. See, it is rather unusual. I agree with Dr. Atanu, but I would have liked to have the depression scores also, because we know very well that along with anxiety in elderly, there is associated depression. And depression can also bring down your scores and your memory complaints, especially if she's improving after a certain period of time. So I would like to have had the depression scores on her. And as Dr. Atanu says, we cannot rule out organicity. It's not good to label the patient in the first visit or the second visit as having this dementia or that dementia. And I think a serial follow-up of the patient, keeping cautious watch on how she progresses, along with more detailed neuropsychological evaluation. I think you will need a more detailed neuropsychological evaluation.
Can donepezil be implicated for the improvement in the symptoms?
I have seen patients with minimal dose of donepezil, they show an improvement. But then again, we must keep in mind that before starting, we should have been reasonably certain that we have rolled out pseudo dementia, as well as we are certain with a detailed neuropsychological assessment that there is a definite impairment.
Okay. So should we go ahead?
To move on. Yeah. Well, so this is
Before we
yes.
well, I'm supporting all the others. My first diagnosis, as I was hearing this, the short history to start with. Second, the relatively kind of subacute, if you will say, presentation, where she completely forgets that her daughter was married. And then it's very patchy. She just doesn't remember recipes and has to call people for recipes, but she remembers many other things. The tendency to kind of give up when she's doing certain tests and towards the end, or somewhere like that. And I totally agree with Atanu and with Manjari. My diagnosis, I was thinking this is dissociative amnesia in a patient with depression after the daughter's marriage, and then it was kind of slowly improving with your psychiatric drugs and everything else. Now, whether this depression would eventually trigger Alzheimer's disease or not is a moot point. But the diagnosis and the treatment, I think, would be in lines of depression. Yeah.
Thank you, sir. So I'm going to follow up with things. Yes, the patient still has minimal symptoms, independent activities, but are still patient is about further loss. Both the psychiatrist and the cognitive.
Your line is
because,
breaking up. Autry, your line is breaking up for some reason.
so is it audible now?
It is.
Hello?
Yeah, it is, but just breaking up for some reason. Anyway, please carry on.
So when she came after 2 years, still she had many memory symptoms and more memory symptoms. And there were observed by the family. By the MMSC, it was 58 by 30. To believe there's 28 or 2 points out of 3.
I can't hear you very well. It's breaking up. Is it okay for everyone else, or is it just my computer, or is it?
It's breaking.
Yeah.
The sound is cracking in between.
Yes.
Atri, try again.
Maybe if you shut off your video, it will be better.
Am I audible now?
Yeah, perfect.
Yeah.
Yeah, please carry on.
So sorry for the problem. Just a moment. Play. Okay, so at 2 years, the patient had minimal symptoms, was otherwise independent, still had depressive symptoms and particularly hopelessness around the persisting memory problems. But the family members were assured because they are not seeing any change. So I just did the MMSE and there was NPIQ was 5, so positive in depression and anxiety. So I asked her that she should continue to follow up with her psychiatrist and also in the cognitive neurology clinic. Now, after 3 years, now when she came back at 3 years, the patient now complains of a significant increase in her memory symptoms. And she feels that she's unable to perform basic tasks due to memory problems. She has stopped cooking because she could not remember whether she has put in spices. She has stopped going out to the usual friends' places because she's afraid of losing her way. She still cooks, but cooks simple meals or cooks a breakfast. She can use a smartphone, plays word games with her daughter. Again, the husband and daughter doesn't observe significant change. And but they acknowledge that she is much less confident about her day-to-day tasks. And so they would keep a watch on her medications, whether she's able to remember her medications. At this time, she was also diagnosed with hypothyroidism and started on treatment. And she is continuing on sartreline and donepezil. Now, examination. Now, MMSE is slightly lower than before, and MOCA is significantly lower than before. I'm going to show you the MOCA. So you can look at the trail B task. So she was making an error at the very end, but now it seems that she is unable to progress beyond the first couple of circles. The clock drawing again has a similar pattern, crowding at the very end. Memory has again delayed recall, slightly improved before and now has started declining. The memory subscore is also declining. The phonemic fluency is declining. Repetition, she used to lose 1 point generally in the past assessments. Now she is losing 2 points. Orientation is preserved. So at this point, I ordered a PET CT scan. So this is the PET CT scan. And in the PET CT scan, there was evidence of atrophy, most prominent in the medial temporal lobes, which would corroborate with the symptoms. And but otherwise, the relatively paradoxical metabolism appears to be preserved. The area that is atrophied in the medial temporal lobe is also hypometabolic. There is hypometabolism there. So 3 years after the on follow-up, so now we can see in the ATN framework, we have N positive for sure. At this time, again, there were no biomarkers available. So now I kind of became confident that this memory problem that it improved and that worsened, that there is an underlying neurodegenerative disorder. And then explained this to the family. And continued with follow-up. Now, 4 years, Now the patient has come back, and with a further decline in memory, they recently, like a couple of weeks ago, they went for a short family trip. And she could remember that she went for the trip, but she could not remember the hotel, how they traveled, how many days they stayed. So all those details were lost. She often misplaced her phone, and for the medical appointments, she could remember them before, but now she required reminder from either the daughter and the husband. She continues, so her sleep initially improved, but now it's again disrupted. So she wakes up 3 to 4 times a night and barely sleeps 3 to 4 hours. But there is no excessive daytime sleepiness. Examination. So the physical examination showed just one interesting point, that our facial expression seems to have reduced. So significant hypomemia, but there are no other Parkinsonian signs at this point. MoCA has declined by another point, and CDR-SB is gradually rising. NPI-Q remains almost the same. I'm just going to show you the MoCA, and you can see that she's unable to do the trail B task anymore. The Q has deteriorated. The clock again is worsening, and the memory subscore has now further worsened. The phonemic fluency was low, it is kind of almost in the same range. So at this point, the blood-based biomarkers became available. So I requested the blood-based biomarkers, and the ratio was significantly above the cutoff. So I'll just stop here and request our chairperson and moderator to share their thoughts.
Yeah, so if I can say, so we were on the right track, obviously, because this person originally presented with depression and symptoms related to depression. As we know, late onset depression can eventually trigger Alzheimer's disease, or probably that is what we are seeing now. I was a little surprised that you didn't have temporoparietal hypometabolism on the PET scan. A little surprising. But otherwise, kind of at the end of the day, it is slowly showing the typical clinical features of Alzheimer's disease. Blood-based biomarkers. Yes, because you were fairly certain that this is going towards Alzheimer's disease. I would put kind of some weight on the blood-based biomarker result. I would love to have a CSF biomarker here if possible. But yeah, so I think so that's depression eventually leading to Alzheimer's disease.
This is a wonderful example of how to follow patients. And since the blood biomarker is positive, if a patient consents, then lumbar puncture biomarker.
Yes, madam. It's scheduled later this week. So we are going to do it next week.
And it is also emphasized here that the behavior and psychotic symptoms in dementia are basically the integral part, and we should be looking towards these behavior symptoms. Like in your case, it was anxiety and depression. We have to follow these patients as you have done. This is also very
Yes.
important because cognition may not be there in the initial part. Your MMSE and your MoCA was like on the normal side. But as you have followed the MoCA and the MMSE has reduced, so the behavior symptoms can be a kind of pointer towards degeneration in the initial part.
Very well documented by serial testing and serial
Yeah.
scores, and also the qualitative assessment is important. Also, sometimes the MMSE may be misleading. Here also, Othria showed that many a time the MMSE score came out to be almost to the upper range, but the other test, and if possible the detailed neuropsychological assessment is to be done in such patients to document that the domains of cognition, other domains which are not being picked up by these short clinical examinations may also be helpful. But as all of you have told that this is a learning for all of us that well, nowadays it is more important that not to miss any patient who is suffering from Alzheimer's disease. And if you want to pick them up, it is not only that the typical cases, but also some unusual presentation. Maybe the neuropsychiatric presentation of this patient was the forerunner of the primary disease. And that was primarily thought to be a depression and anxiety, but which turned out to be a case of neurodegeneration pathology in the brain.
So I just have a few thoughts to share. This one is kind of for the residents. We all come across this table repeatedly. So this patient would kind of go into the amnestic multi-domain MCI at the initial presentation before she progressed. And at that time, out of the differential diagnosis, both AD and depression were present. There was no evidence of any vascular changes in the MRI, no history of stroke. Although the patient had vascular risk factors, they were very well controlled. Moving on, so given the fact that the patient stayed in that MCI stage and continued to follow up in this MCI stage, if we had the biomarkers then, would it have helped us? So this is a study that was published in European Journal of Neurology in 2023, where they examined when you do biomarkers in MCI patients and how accurate is the prediction of progression. So they compared patients who remain stable over 3 to 5 years and compared to patients who progressed, and the accuracy of prediction of these biomarkers. They used a panel in comparison to the p-tau 217 that is available in India. They use p-tau 181, and the AUC it seems is 0.8, 0.81. So very comparable between these three. When they combined these three for into a statistical model, the predictive ability significantly increased. So I don't know whether this is going to be the future approach. And finally, I'll finish with this table. This is a paper that came out in Nature Aging last year. So this this study had a very large sample size. This is nearly 7,000 patients, where they examined the positive predictive value and the negative predictive value of the biomarkers. So the sensitivity and specificity is is close to 90%, as we know, for all the biomarkers. But suppose the patient had come to us and with the biomarker when, suppose in the first visit or the second visit, when the scores were improving, the patient was still in the MCI stage. So how predictive would have been the biomarkers? So 2 points. One is the age. So as you can see, the positive predictive value of the positive biomarker result kind of increases with age. So when the patient first came to us between 60 to 64, the positive predictive value would have been 77%. So there would have been a 23% possibility that this might not be an Alzheimer's disease patient. The negative predictive value is much higher. On the other hand, when the patient converted to probable AD as per the clinical criteria, the positive and the biomarker is positive, then the positive predictive value is nearly 100%. But the negative predictive value is low. So I guess this suggests that if a young patient with MCI, with cognitive multiple confounding factors, including poor sleep, depression, and you have a positive biomarker, then possibly we still need to confirm it, as Madam had mentioned before, that we still need to go ahead and confirm. And in absence of amyloid PET, we will possibly need CSF biomarkers as a particular application in this group of patients. So with that, I would like to thank Madam and the cognitive neurology subsection, my teachers who taught me cognitive neurology, my colleagues, and the patients and the caregivers. Thank you.
Thank you, Dr. Atri, for the wonderful presentation, and we had a lot of learning points from your this case.
Stop sharing.
Yeah. So, can we move on to the second case?
Yes,
The-
please carry on.
Yeah. Dr. Anu Gupta, and the resident will be presenting the case.
So thank you, madam, for this opportunity. Thank you, sir, for this opportunity. So after a very beautiful case presented by Dr. Atri, I think the case that we are presenting is a little different. So this patient has come to us 4 years down the lane with some atypical symptoms early on in the disease. And what we would like to highlight through this case is that any particular symptom that a patient comes with may have multiple players or multiple possible localizations in the background. How do we disentangle this symptom conundrum and reach the correct syndromic diagnosis? Because a correct syndromic diagnosis will ultimately help us in forming a correct etiological differential and will guide our investigation plan. So that is what will be presented by Dr. Sapna Mittal. So we will take brief halts in between and take the opinion of our esteemed chairpersons. So Sapna, you may start.
Hello. Good morning, everyone. At the outset, I would like to thank the IAN for giving me this opportunity. I would also like to thank my HOD, Dr. Manjari Tripathi, to give me this opportunity, and Dr. Anu Gupta ma'am to guide me through this case. So we'll start the case now. I'll be presenting the case of a 57 years old female, right-handed individual, homemaker, educated up to BA. History was given by presented to us with chief complaints of forgetfulness for 4 years, difficulty writing, dressing and navigation for 2 years, difficulty reading for 1 year, and pain in the left upper limb for 1 year. So the detailed history goes like this. Around 2022, the patient's relatives noticed forgetfulness in the form of misplacing objects such as TV remote, Aadhaar card, money or certificates. She was able to find those objects later, but it took time and effort. She could do all her daily activities like drive a scooty or cook or shop for her daughter's wedding and participate in the wedding rituals. And she could remember recent events and conversations at that time. Around 2023, she started to forget objects in inappropriate places. Like she would leave the potato peeler with the peels and would throw the peels and peeler in the dustbin. She would also occasionally leave the gas on. She went to a marriage function with her friends and had difficulty finding the toilet and her room at the new place. When the friends reported this to the family, she got evaluated by the neurology services and she was thought to have amnestic MCI at that time and was prescribed donepezil. Her OPD card also mentioned that she had a difficulty in wearing dresses and difficulty in counting. Around 2024, her navigation difficulty became more noticeable. Patient went to her maternal home and went to her relative's house across the road. While coming back, she could not find her own house, although she was standing in front of it and had to be helped by the relatives. Her son had shifted to a new house, and whenever she would visit this quarter, she would enter someone else's quarter thinking that it was her son's house. Inside the house also, she was having difficulty finding the kitchen. The kitchen would be in front of her, but she would walk in the opposite direction. At times, while coming back home, she would miss the tree where she was supposed to take the turn to reach her house. She would say that she could not see that tree. She could recognize objects and faces. She did not bump into objects. She was able to eat food from the plate. She did not neglect any side of the body while dressing. But she continued to have other dressing issues in which she would wear clothes inside out or would try to put her head into her sleeve. Around 2025, her writing difficulty became prominent. when the son was giving her tasks to check her writing and reading. So she was writing individual letters and it was very slow and difficult. Family also noticed that while reading, she would skip words. While reading phone numbers, she would skip some numbers, and she could form the sentences verbally, could understand all the instructions, could name common objects. Recently, she started becoming more quiet and less enthusiastic about family outings. She had mild decrease in appetite, but sleep was okay. There were no crying spells, no disinhibition, aggression, food feticism, compulsive behavior, or neuropsychiatric symptoms. She had some difficulty finding words but could produce meaningful sentences. She required cues to recall recent events and at times missed the details. She also complained of pain in her left upper limb, which had appeared for around 1 to 1.5 years. She would open and close her left fist repetitively. There was no history of feeling that limb was not her own or exploratory or other purposeless movements of that limb. Family also observed occasional tremulousness of her left hand, and there was some slowing while walking and doing her daily activities. There were no falls. She was able to, some of her ADL she could not do, like she stopped driving scooty, she could not go out alone and stopped cooking, but her basic ADLs except dressing were preserved. There were no sleep disturbances, fluctuations, hallucinations, or seizures. In the past history, she was a known hypertensive for past 6 years, which was controlled on medications, and she was type 2 diabetic mellitus for past 4 years, for which was also controlled on medications. Her diet, she consumed a mixed type of diet, sleep was adequate, appetite was reduced a bit, and bowel bladder habits were unaltered. There were no similar complaints in any of the family members. So summarizing the case, we had a 57-year-old female with 3 to 4 years history of misplacing objects and navigation and dressing issues, followed by difficulty in writing and reading. And of late, she was having difficulty in finding words. There was slowing and pain in one limb. In the background of hypertension and type 2 diabetes mellitus without a positive family history.
So, our respected chairpersons, I would like to take your opinion. How do we put together all these symptoms, and what kind of possible syndrome we are dealing with over here?
Tanu?
Yes, very interesting observation indeed. And relatively young, it is almost 57 years. So the disease started 4 years back, almost in the early sixth decade, the disease started. And initially, the symptom was quite that of the amnestic symptom, forgetting, or the forgetfulness of episodic memory loss like that. But soon the symptoms complex moved to the difficulty in recognizing her own house, recognizing a direction and finding a route. And this means that the hippocampal, parahippocampal formation, and also there was some navigational problem. So there was occipito-parietal part was also affected. Then quickly, she also had difficulty in dressing. So there was some parietal dysfunction. And then the dominant hemisphere, the reading and writing ability got disturbed. Again, the posterior language area and word finding problem. But more importantly, the patient also developed motor symptom, and that was asymmetric tremor, pain, although not typical of dystonia from the history, but there was some abnormal movement in the hand and pain and suggesting some extrapyramidal involvement. So the localization spread from the medial temporal lobe to the parahippocampal formation to the parieto-occipital bilateral and the language area. And of course, because she has a left upper limb motor problem, so maybe it is a form of asymmetric pathology in the right parietal cortex or the cortex and the subcortical basal connections. So we are dealing with pathology that is widespread. It started probably in the temporal lobe, that is the odd, but moved quickly to involve the parieto occipital as well as the parietal cortices. So it looks like not a very typical pattern of involvement in Alzheimer's disease, and pathologically, I would rather consider this as an Alzheimer's pathology because it has involved so many structures, not only restricted to phenomenology of corticobasal syndrome, but corticobasal syndrome is probably a Alzheimer's pathologically Alzheimer's disease. So this is what I personally feel.
Thank you, sir. So, Sapna, can we go on to the examination?
We would like to go through the symptom analysis. I'll go in a bit of hurry because sir has already analyzed the symptoms well. So first, her symptom was misplacing objects. So different patterns of misplacing objects can be seen in dementia. So one is lost and found, where the person places the items normally but fails to register or consolidate the spatial memory. And then patient searches in the logical spots, which localizes to the issues in encoding, so frontoparietal networks or storage, that is right medial temporal lobe. Or there could be hiding away type of phenomenon, where the patient actively hides the items to keep them safe and then forgets due to concurrent memory deficits. Patient may exhibit paranoia, and later the objects are found at those unusual places. So here the frontolimbic circuits could be involved, or the odd places phenomenon, where the patient stores objects in highly inappropriate and illogical locations, like keeping keys in the freezers or dirty dishes in oven, etc. So that means that patient has lost the concept of the things and where the things are to be kept. So that suggests involvement of semantic networks. In our patient, it was more of an attentional issue, localizing to the frontoparietal networks. Then another issue was the navigation difficulty. So multiple players can create navigation difficulty, like there may be issue with understanding locations with respect to self or landmarks, which localizes to right parietal lobe. There could be attentional deficits, which also localize to right parietal lobe. There could be difficulty in recognizing landmarks, which localizes to temporal lobe. Or there could be difficulty in zooming out and forming a mental map of the routes, that localizes to parietal and medial temporal lobe. There could be also difficulty in learning the new routes. So it localizes to the right hippocampus and parietal connections. In our patient, we feel that it was multifactorial and predominantly parietal lobe involvement. So for the bedside test that can be done for parietal lobe, we can see how the patient is navigating in the ward and how the patient is locating states on a map or recognizing famous buildings, for which patient should have prior knowledge about those buildings, or the attentional deficits can be tested bedside. Some formal tests are available, like lead-in navigation test, in which some videos are shown to the patients and later multiple questions are asked to localize the navigational issues, but they require proper attention, processing speed, and visual acuity. And then such tests need cultural validation in art settings. Then another issue was writing difficulty. So writing difficulty can be because of motor issues, where the paresis or extrapyramidal or cerebellar could be involved, or it could be because of visuospatial problems, where the patient might confine to write on one side of the page, or there could be slant lines, or there could be abnormal spaces between the words, which localizes to non-dominant parietal lobe. There could be apraxic agraphia or pure agraphia, where the loss of movements to write the letters or words is there, but the knowledge is okay and reading is also okay. There is no aphasia. It localizes to left superior parietal lobule. Then there could be alexia with agraphia, which localizes to left angular gyrus, in which there will be difficulty writing and spelling, and there will be associated central alexia, and all writing modalities, including copying, will be affected. And then there is aphasic agraphia, where copying will be preserved, but writing direct on commands will be affected. So in our patient, it could be visuospatial, or it could be apractic, as her limb was also involved in some way, or it could be parietal. We need to examine further for the same. Then there was reading difficulty. Reading difficulty could be because of the issues in the primary modality, like visual acuity is affected, visual fields are affected, or impaired saccadic movements, or it could be attentional dyslexia. Sometimes because of neglect also, reading can be affected, which localizes to right hemisphere, especially inferior parietal lobule. And in the presence of simultaneous agnosia also, the patient won't be able to read the words, read the sentences normally. They will be able to find the words and able to read the separate words properly, which localizes to parieto-occipital area. There could be pure alexia, in which patient reads letter by letter and uses kinesthetic cues to read. It may be associated with hemianopia. It localizes to left occipital plus splenium involvement. Or there could be alexia with agraphia, which localizes to dominant angular gyrus, or there could be aphasic alexia, where dominant perisylvian language networks could be involved. So we feel, based on his history, that it could be attentional, but we need to examine further to confirm the localization. Other features were occasional word finding difficulty was there. There was dressing apraxia, which localizes to right parietal lobe. Patient was quiet and less enthusiastic, which suggests apathy, and or it could suggest beginning of language disorder. There was pain in her left upper limb, so we need to look for motor signs. So all in all, there was a significant parietal involvement, right-sided suggesting difficulty in dressing and navigation, and left-sided suggesting difficulty in writing, reading, and calculation. And parieto-frontal networks, which could be explained by the attentional issues. And for the left upper limb, we need to examine for the motor signs. So clinical possibilities considered at this point were posterior cortical atrophy and Alzheimer's disease at the end of history and symptom localization. Now I'll go ahead with the examination. Patient was conscious, alert, cooperative, adequately groomed, but she had slow information processing. Her MMSE came out to be 20 out of 30. In the orientation to time, she could not tell date and day, and in orientation to place, she could not tell floor. Registration, she could register 2 words at first attempts and required 2 to 3 trials to remember all the 3 words. In attention and calculation, she could not perform the serial 100-7, but she could spell the 3-letter word backward in Hindi and could name 2 to 3 days of the week backwards. Delayed recall, she could recall 2 out of the 3 objects, and with phonemic and category cues, she could recall all the 3 objects. Naming was fine, reading was fine, writing and copying she could not do. For the repetition, it was intact for 3 to 4 word phrases, and on longer sentences, she was not able to do it. In the 3-step command, she forgot the 3rd command. So overall, her MMSE was 20 out of 30. In the detailed higher mental function examination, attention, her digit forward was 3 and backward was 0. In the A random letter test, there were multiple omissions, and she could do the task initially, and later on she forgot what she was supposed to do. In the language, her spontaneous speech was fine with normal grammar and prosody, but there was some word finding difficulty. Category fluency, she could tell 9 vegetables in 1 minute, and in verbal fluency, she could tell 2 words with the letter P and 2 words with the letter M in 1 minute each. Comprehension, simple commands were normal, yes, no responses were normal, but on complex commands, it was impaired. In the repetition, she could repeat up to 3 to 4 word sentences, and on longer sentences, there were phonemic paraphasias. In the naming, she could name 8 out of 12 items on ACE3 spontaneously, and retrieved all the missed responses on giving category cues. So there was a logopenic flavor to the language. This is the example of her reading, where after reading the first line, she was circling around on the right side of the page. She was reading the paid paudhe 2-3 times. Then she directly went on to the second line last word, then to the third line last word, and then again came back to the first line last word. And when she was told to read on the left side, she again started from the first line of the page. So it suggests some sort of attentional issues, attention issue also, and neglect also. There was, like, she was not reading on the left side of the page. And in the copying, she could not copy this word. In the frontal lobe testing trail, A and B, motor luria, graphic luria, and conflicting instructions, go, no go, nothing she could do. In the verbal similarity and proverb interpretation, it was normal. Category fluency, she could tell 9 to 10 in a minute. Judgment and insight were intact, and there was no environmental dependence. The trail test and lurias could be abnormal due to problems with visual spatial processing as well, and they do not necessarily indicate severe frontal involvement. In the recent memory, orientation to date, day, and floor was impaired. Recent experiences she could describe with cues, but missed the details and timeline. In the new learning ability, she was able to register 3 words at 0 minutes, but not beyond 3. And she was unable to recollect more than 1 word at 5 minutes, but it was getting better with phonemic cues. Visual memory, she was unable to locate the objects given in space to her. In the remote memory, she could tell the personal information correctly and could tell in detail about her 6 children, their job, place, age, and even the classes in which her grandkids were studying. Semantics were intact and historical facts were also correct. So the impaired performance on these tests of learning ability could have been impacted by her language and attention and encoding issues. In the parietal lobe modified letter cancellation test, she was unable to identify the big letters. In the Neven diagram, she was unable to identify the bigger letter. In the mixed figure test, it was impaired. I'll show the picture in the next slide. And she could not identify the degraded letters and could not count the dots in the ACE examination, in the ACE performer. And in the picture description also, she could tell only the individual objects. So this was the modified letter cancellation test in which she misses all the big A's and she is able to identify the small A's. One of the small A she misses on the extreme left of the image. And in the Neven figure, she could tell that there is the letter S, but she could not tell the letter, the big letter C. This flag, which we had shown her during her Edenbrook's performer, she identified this as a chakra. She could just see that central part and she could not identify the flag as a whole. So this was the mixed figure test in which she identified the middle part of the butterfly as a fish and the side of the butterfly as a cockroach. Other than that, she could not identify any of the objects in the mixed figure test. And in the picture description also, she identified a tree, a man, ducks separately. She could not see the whole figure as a whole. And in both these tests also, we see that she is neglecting the left-sided visuals. So there was a deficit of spatial attention. She could not draw clock or copy figures. In the praxis examination, she could not imitate gestures or do multi-step sequencing. She could do very simple calculation. Right-left orientation and finger agnosia were grossly okay, but she could not show it on the examiner. She could do it on herself. On bilateral simultaneous stimulation, there was left-sided neglect, both on visual stimulation and on tactile stimulation. Stereognosis was normal. Object recognition, matching, face recognition, color naming were normal, and occipital lobe functions were normal. There was a problem, overall there was a problem with scanning a complex environment when multiple stimuli were given, and she was stuck usually on the one side of the visual field, which could suggest simultaneous agnosia or it could suggest neglect as well. In the motor examination, we can see that there was dystonia in her left upper limb. And in the second figure, we can see that there was optic ataxia. So after examination, we can summarize it in the form of there was mild disorientation, there was difficulty holding auditory online information, immediate memory and encoding difficulty. There was logopenic flavor to language, there was reduced forward digit span, repetition, and there was degradation of longer sentences with phonemic paraphasias. Naming improved with phonemic cues. There was preserved grammar and single word comprehension. Visual spatial deficits were suggestive towards the Balint syndrome. and there was difficulty in navigation, dressing, and there was a component of neglect also on examination. Her agraphia was sort of aprectic, because language was very mild, her spellings were correct, and copying was affected. And she also had attentional alexia. There was asymmetric rigidity and dystonia. So I'll go ahead with the possibilities at the end of examination. So after examination, there was we thought of corticobasal syndrome as well because of the prominent motor features, which we confirmed on examination to be having dystonia. So it could be PCA, it could be CBS, or it could be an overlap. I'll go ahead with the imaging findings now. So her MRI brain was suggestive of significant parieto-occipital atrophy with some frontal atrophy as well. And there was involvement of temporal lobes bilaterally as well. The ASL also showed hypoperfusion in the parieto-occipital area. The PET brain was suggestive of right more than left parieto-temporal occipital hypometabolism, including the precuneus and posterior cingulate gyrus. And further investigations showed plasma and CSF-AD biomarkers to be positive. So biologically, it fitted into the criteria of Alzheimer's disease with the PCA dorsal variant and PCA plus because of the involvement of presence of motor symptoms. So PCA CBS phenomenon. So this was just about the PCA subtypes. We won't go into the details of this. And this is due to lack of time, I'll skip this. This is the criteria for diagnosis of corticobasal degeneration, in which our patient was fitting into the probable CBS in view of presence of rigidity and dystonia, also associated with apraxia and cortical sensory deficit. So this was one study in which motor features in PCA were studied. So 44 PCA patients were taken, out of which 30% had prominent asymmetric limb rigidity, apraxia, and some of them even had myoclonus. Their imaging features and biomarkers suggested PCA variant and like Alzheimer's disease. So PCA motor was thought to be as a heterogeneous variant of Alzheimer's disease. So at this point,
here I would like to take a brief comment from our chairpersons. One is that so if we had seen this patient maybe 2 years before she presented and she didn't have motor symptoms, we would have labeled it as posterior cortical atrophy. But we see that how these diseases can evolve and develop symptoms which may overlap with other syndromes. So, and the second question to our worthy chairpersons would be, now for this particular patient in today's era, when we have biomarkers, her biomarkers are positive and her MMSE score is also not that low, should we consider her for anti-amyloid therapy?
First of all, let me congratulate Sapna and Dr. Anu for presenting a very illustrative case and well worked up. The test she has done meticulously is to be learned by all the residents in this country, because this is how we should proceed. And for that, I congratulate both of you and Dr. Manjari for guiding her. And as very well stated that this patient, yes, we are seeing the patient after 4 years of the disease onset. The disease started, I personally feel, at the initial period, probably, and there was some involvement in the hippocampus and the areas as well, because soon the symptoms of parahippocampal gyrus and also the connection between the hippocampus and the parietal cortices, the recognition of the landmarks got lost. Then the navigation problem also started, and then whole lot of parieto-occipital symptom, and we demonstrated the simultaneous, the Berlin syndrome, and of course there was some form of language impairment suggesting that of a logopenic variety. So symptomatologically, the pathology and the pathology spreads from the parieto-occipital, parieto-occipital-temporal, as well as the temporal cortex. And little symptom or the findings was observed, suggesting there was some frontal dysfunction. More importantly, this patient has a diagnostic criteria fulfilling the PCA, but also fulfilling the criteria of CVS, because she has very prominent asymmetric dystonia and of the left side. So this is an overlap, and pathology in both these conditions, if you put together, the Alzheimer's comes fast, because there is the PCA usually is a domain of the majority of the cases are Alzheimer's. And if the CVS is also there, the CVS cannot be, we cannot account for this and separate pathology like tau pathology or other than this. Sometime the CVS or the PCA can be a presentation of the CJD, but that usually comes very rapid, with rapid progression, more myoclonus and others. But in this patient, that was not there. And very importantly, the biomarker came out to be positive as well. So very well documented and patient. But regarding your second question, whether to give the benefit of anti-amyloid treatment in this patient, we are in a very early stage of using this drug. Maybe some of us have used this, but in the initial period, we are restricting our therapy to those who primarily come with the typical amnestic syndrome. The atypical variety of Alzheimer's disease has not been studied in any of the trials. So this needs to be considered. Although if the patients and the relatives are very eager, then the question will come, but then the senior experts will comment. But I personally feel that as because we do not have the experience of using this and how these patients will benefit, we do not know. So here it is better not to try, rather than try to in those patients who are in a typical Alzheimer's symptoms or Alzheimer's patient in the early AD or dementia stage.
So we have one question from the audience. Are we relying too much on the plasma biomarkers to resolve the complex clinical problem? Is it too early to put all your money and trust on a newcomer? He wants to have this answer with the experts, to the experts.
So,
Yes.
yeah, so if I can answer, yes, you're
Yes.
right. I think it's extremely important to recognize, like everywhere else, you don't treat a test. You treat the patient who has the test. So plasma biomarker as of today, even 3 weeks ago, the Alzheimer's International Conference which happened, people were expecting that the plasma biomarkers before that would have been approved by the FDA or whoever is important. It has not been. We know everyone is pushing for plasma biomarkers, and this is probably going to happen very soon. The reason being that plasma biomarkers, first of all, you need to have who is doing, what is the chain of collecting the plasma, where is it going, which lab, how long does it take, how quickly is it spun down, where is it stored, what temperature, everything is important for plasma biomarker. That is number one. That is the technological part. Second is, do you have a strong clinical suspicion that this is Alzheimer's disease and nothing else. If you have a strong clinical suspicion that this is Alzheimer's disease and nothing else, then does your plasma biomarker result taken correctly cross the upper limit? There are two cutoffs. Does it cross the upper cutoff? If all of three fit, then you say it is more or less confirmatory this person has Alzheimer's disease. And then if you want to give the AD therapy, the anti-amyloid therapy, you still have to do, you still have to do the CSF or do an amyloid PET and see, nowadays they do quantitative to look at the centiloid scores of the PET, but amyloid PET has to be positive or CSF has to be positive. So therefore, plasma biomarker is very good, exciting. Where is its benefit? Its benefit is if the patient has below the lower cutoff, then the negative predictive value is 97%. That means for all practical purposes, this patient does not have Alzheimer's disease. So that is the most important thing of plasma biomarkers as of now. I think very soon, maybe by next year, it will be taken as confirmatory, but there are a lot of technicalities. Second, in India, let me tell you, we are using a biomarker which is made by Agape. It's MISBA biomarker. This has been recommended by the Lumipulse group, the Fujirebio company, and they have said that this is exactly the same. They have set it up apparently for India, but the MISBA is still not FDA approved. So for us, the MISBA is a very, very strong indicator that this is AD, very strong. But you still can't replace that with the Fujirebio Lumipulse. You shouldn't do that. It's very important. I mean, people are not discussing that. I do a lot of plasma biomarkers, but I'm very still cautious when it comes to this particular point. I will do a CSF if I need to give this patient anti-amyloid. So I hope that answers your question.
Thank you, sir. Thank you for very, very insightful comments. In this case, actually, the patient's son was himself a doctor and very, very motivated to go ahead with anti-amyloid therapy. So we went ahead with the CSF because our FDG PET, the clinical picture, and the plasma biomarkers were all in one direction. So we went ahead with the cerebrospinal fluid testing using the Alexis assay, which is FDA approved. And the patient had a clear-cut positivity. Her ratio was 0.04. And
Did you
after
went
a
ahead
thorough
with
explanation regarding the benefit and the risk, so we went ahead with the therapy. Just 2 or 3 slides Sapna will show. Sapna, can you quickly go through?
So before starting anti-amyloid therapy, we need to see some points that it should be early symptomatic AD. MMS should be 20 to 28. There should be ApoE genotyping, which is required, and MRI features also are to be looked at. I'm not going into details of it. So in this patient, the MMSE was 20, CDR global was 1, and Barthel index was 90. We checked for contraindications in MRI, there were none. ApoE testing showed 3 homozygous. So we gave her first injection of donanemab 350 mg in the first week of July. There was no infusion-related reactions. And then a repeat MRI was done in the first week of August, where there was no evidence of ARIA A or ARIA H or any other complications. Then we administered a second dose of injection donanemab yesterday only, 700 mg, and there was no infusion-related reaction. This was the this was the repeat MRI, which did not show ARIA E or ARIA H. So in conclusion, we would like to say that difficulty with the cognitive function can have many underlying reasons, and a detailed history and associated features may help. Examination should be targeted to identify the primarily affected domains and understand deficits secondary to primary afflictions. We need to correlate our findings and diagnosis with the investigations, and treatment can be offered in atypical features based on clinical judgment and after detailed explanation to the family. I would like to acknowledge patient's family our senior resident, Dr. Pratik, and our faculty in the different departments.
Thank you, Sapna.
Thank you.
You can
Aman,
log out.
over to you.
Yeah. So, I would like to ask question with Dr. Abhintaba and Dr. Atanu. So, as Dr. Anu has already given the anti-amyloid therapy to an atypical patient, posterior cortical atrophy. So, sir, what is your take on for treat? Because we are having these kinds of patients in our OPDs, and some of them are wanting to have the therapy. So, what will be your take on for these patients for an anti-amyloid therapy? The atypical patients, the young
Yeah.
atypical patients.
So Dr. Atanu has already,
You can
told
log
you
out,
that.
Anu, the slides.
Yes, ma'am. I'll
Sapna,
stop.
So
please
Dr.
stop sharing.
So Dr. Atanu has already explained why it's kind of difficult
Yeah.
because we do not have strong evidence on these patients. It's all on kind of primary amnestic patients. But one of the AURs, if I'm not mistaken, is the US AUR on lecanemab, who actually allowed, they put those things there. So they put PCA, they put the logopenic variant, and I think they put the executive variant as well, if I'm not mistaken, in that, and they said, yeah, you can use it. Now, so there is no answer. I mean, if you want to use it and the patient is strongly wanting to use it, I think we have no choice but to go ahead, but to explain all the pros and cons about this. Because at the end of the day, if they choose and I don't give, I'm allowing the Alzheimer's to progress, knowing that this was actually Alzheimer's disease. And if the whole fundamental principle is removal of amyloid from the brain, then what's the point of not giving it? So that's the issue. There are two small things. One, as again, what we have already discussed, that there is no hard evidence on this group of patients that it works. The second is patients, especially those with aphasia. I mean, you have to do these tests from time to time and see how the patient is doing. For example, if a patient is declining in their cognitive performance, you are supposed to stop the drug, not carry on. So if they go from mild to moderate, you're supposed to stop the drug because there is no treatment for moderate. So it's things like that, little technical issues we have to be careful about. So I would say it depends on patient to patient. If they ask kind of someone like the Cognitive Neurology Association, whether we would give or not give, I think we have no business to say, go ahead and give. We have to say, discuss with your patient and.
So we need more experience, more investigations for extending this treatment to the atypical cases. So at the end, I would like to thank the chairpersons, the attendees, Dr. Anu, Dr. Sapna, and Dr. Atri for presenting the wonderful cases. And we have a very good discussion. And at the end, I would like to thank IN President and Secretary and Ashmita for making this happen on the IN. Thank you very much for attending.
Good. Thank you.
Thank you.
Very much. Thank
Thank
you.